huge welcome to everybody. Thank you so much for coming. I'm Lorraine, and I run the Thyroid Trust along with a fantastic board of trustees and amazing team of volunteers. And we've got with us today our speaker, Dr. Bernard Khoo. Wave, Bernard, and some people can see you, who's very kindly given up his Saturday to give us a talk on some research that he and some colleagues published in November of last year about thyroid hormone function in COVID patients. So I know we're all very eager to hear that talk, and huge thanks to Bernard for giving up his time. I'd just also like to briefly introduce our Chair of Trustees, Judith Taylor. Give us a little wave, Judith, or a little nod. Judith is also part of the Thyroid Cancer Alliance, and she and the Thyroid Cancer Alliance are very kindly hosting today's talk on their Zoom account, as they have been doing for all of these webinar events that we've been doing through the pandemic. So we're very grateful for that support. It's extremely helpful, obviously saves us a little bit of money as well. And I'd also like to introduce the two volunteers who are going to help try and manage today with so many participants. I've got Karen George. Karen, give us a little wave. Who is one of our trustees and has been involved with the Thyroid Trust since the very beginning. She's going to be helping out today. And also Helga Taylor. Helga, give us a little wave. Who again is a fantastically helpful volunteer and is very actively involved in all sorts of thyroid patient campaigning, and worked quite closely with me on the campaigning work that we did for T3 Access, or we have been doing for T3 Access since 2018. So a sort of long-standing person who's very involved. So huge welcome to everybody. I'm going to start with just a brief introduction about who the Thyroid Trust are and how we like to run these meetings, because I think that's sort of helpful for everybody to kind of be on the same page with that. And then Bernard is going to give his talk, which he says actually is going to be about sort of 20-25 minutes, which is great because it gives us hopefully lots of time for discussion afterwards, lots of questions. And we've had some questions sent even in advance, which is wonderful. After Bernard's talk, I'm going to share just a few announcements, and Karen is as well, which hopefully will be interesting for everybody. And then we'll have a little 5-minute comfort break, sort of at sort of natural break point between about 11:45 and 12 o'clock. We'll take 5 minutes. So you can step away from your computer and sort of just refresh your brain cells or grab a coffee or whatever if you need to. And then we'll come back and we'll have the Q&A session, a couple of more announcements before we finish up. So you can use the chat function throughout the meeting. So please feel free to drop any questions or comments into the chat as we go. As I said, we have got a huge number of people in the room. It might be quite challenging for us to keep on top of everybody's comments, but we're going to do our very best to do that. That's probably what we'll do is when we come to the Q&A, we'll see who's asked what questions, and we'll call on you, and you can either then say your question, or if you prefer for one of us to read it out, then we can do that. Or if time is getting a bit tight, we might summarise the questions, because sometimes you get a lot of people asking the same sort of thing. So yeah, Thyroid Trust, we're a very new charity. We were registered in 2019 with the Charity Commission, but we were offered funding to start setting up as a new charity in 2017. So we've been working on doing that since then. And actually we grew out of a group of patients who'd been organising meetings with leading clinicians in central London since 2010. So we've been doing this sort of thing for quite a long time. And the funding that we were given was to keep those meetings going, but also to start working on awareness raising and advocacy initiatives, which we've been doing since then. So we're still very new. We're still sort of finding our feet in lots of ways, but we've got big ambitions to really make a big difference for thyroid patients. And we've done quite a lot already, and we're very grateful to all of you for being interested in what we're doing. And particularly, I'd just like to see, very grateful to those of you who have actually made a donation to attend today. That's very, very much appreciated. But I also just want to emphasise the most important thing for us is that anyone who's interested gets to come along and participate in these meetings and benefit from them, regardless of whether or not you're in a position to donate. Yeah, so we have some ground rules that we ask everyone to adhere to when they come to our meetings, and we developed these way back in 2010. And what we found is that if everybody agrees to a sort of way of being together, then we have a really nice supportive environment and a sort of, relatively sort of smoothly running experience where we can talk about everything to do with thyroid stuff. And I know that sometimes it can be very emotive subject. There will be people in the room, I'm quite certain, who may be very dissatisfied with treatment that they've had, may be very frustrated, may be very unwell. And we really want to support all of that. We want to give people a place where they can learn more about their condition, but also a place where they can ask any questions that they may have, and also a place where they can voice whatever they want to voice. However, just want to say, please be gentle. We're all patients here, apart from Bernard, who's very kindly giving up his time, so he's volunteering. Obviously, if you're sharing anything, don't presume to try and give medical advice to anybody else. This is certainly not the forum for that, and none of us are qualified to do that apart from Bernard, and there's far too many people here for him to be doing that with anyone on a one-to-one basis as part of a big group discussion. And also, if you're sharing anything about your own experience, if the conversation goes down that route, obviously don't try and push solutions onto anybody else, because we're all individuals. What works for one person might not work for anybody else. Please allow everyone to have your say. Sometimes people come in and they've got lots that they want to ask and lots that they want to say, and there are, I think, over 100 people in the room possibly. So please be careful not to sort of dominate the Q&A session, and just be sort of respectful that this meeting is for everybody. So with that, I've said quite enough. Let me go on to just properly introduce the lovely Bernard. Dr. Khoo originally trained at University of Cambridge, and as a medical student there, he actually got a PhD in zoology before going on to work at Bart's Hospital, and obtained his specialist accreditation in endocrinology there, and was appointed Wellcome Trust Advanced Fellow back in 2003 to 2006. Since 2009, he's been the senior clinical lecturer at the Royal Free Hospital in London, and he sees over 1,100 patients every year. He works across both diabetes and endocrinology, and I think it's worth sharing his specialist interests. So I think it's very interesting. It's quite a broad number of things that Bernard is very interested in. So endocrine surgery and pituitary disease, as well as thyroid disease and adrenal disease, calcium disorders, neuroendocrinology, neuroendocrine tumours, as well as genetic endocrine disorders, which is a really interesting basket of stuff. And with colleagues, he published a very important new study looking at thyroid function tests in Covid-19 patients in the Journal of Clinical Endocrinology and Metabolism. And it's probably disappointing in a way for us as thyroid patients that study wasn't on thyroid patients, but it's worth just flagging up to everyone that that's the case at the start as well. So it was on people who didn't have a thyroid condition before they got COVID, but then perhaps something happened with their thyroid hormones during the COVID experience, and that's what he's going to be telling us about, which I think is really exciting. I'm really grateful to you, Bernard, for doing this, and I'll hand over to you now without further ado and let you do your talk.
Thank you. Thank you, Lorraine. Just wanted to do a bit of a mic check and make sure that everybody can hear me nice and clearly. Thank you very much. Okay, so just going to get this show on the road. Share. Okay, so second thing I just want to ask is, can everybody see the slides, in particular the little picture of a coronavirus and the cartoon of a thyroid?
Yes.
Oh, excellent. Okay, good. So thank you very much for asking me to talk, and particular thanks to the Thyroid Trust. And today I'm just going to be talking about the thyroid and COVID-19. The reason why this is a relatively short presentation is because, well, frankly, COVID-19 is something that we've only literally heard about 1 year ago. And the information that we have about COVID-19 and the thyroid is relatively small. But hopefully the presentation will be informative to you and give you an idea of where we're trying to go in terms of looking into what the impact of COVID-19 is in the thyroid. So, oops. Okay, so what am I going to talk about? I've just typed something weird and ungrammatical here. But anyway, we're going to start off with what we knew before COVID-19 about how coronaviruses could affect the thyroid. There was quite a lot of publicity earlier on in 2020 about this thing called thyroiditis and its associated COVID-19. And I'm going to talk about our study and why we decided to do the study, which is looking at what happens in thyroid hormone levels during COVID-19, but importantly, what happens before, during, and after COVID-19 infection. We're going to talk a little bit about why we think COVID-19 can affect the thyroid in terms of what the mechanisms are. And I'm going to finish up with a few things which I think may be interesting to you as patients with a thyroid condition in most cases. And is there anything to be worried about COVID-19 more than you would otherwise be worried about? So the first thing is just a simple, basic slide, and what I'm trying to do here is just to give you a little bit of a reminder about how we think the thyroid works. So what I like to say about the thyroid gland is that its job in the body is a bit like the thermostat in the house. In other words, it controls the heating of the body, and the way that the thyroid gland does that is by making thyroid hormones, and you will have heard of T3 and T4. And the main job of T3 and T4 is to essentially turn up the heating by increasing metabolism. Metabolism is basically what we do when we eat food and use food in order to generate energy. But at the same time, we also use food to help fuel our growth and development, particularly when we're kids. So the thyroid gland doesn't do this alone. It's under the control of a boss, and the boss sits near the brain. So the hypothalamus is a bit of the brain, which essentially releases a hormone called thyrotropin-releasing hormone, and that communicates to the pituitary gland, which sits just underneath the brain. And the pituitary gland then makes a hormone called TSH, and TSH is one of the things that we measure when we measure thyroid hormones, and TSH stimulates the thyroid gland to make the thyroid hormones. And importantly to us as physicians and patients, when the thyroid gland makes thyroid hormone, this comes back to the hypothalamus and the pituitary gland in the process called negative feedback. In other words, when you have high levels of thyroid hormones, it goes back to the hypothalamus and the pituitary gland to switch off the production of TRH and TSH, and that way we get a stable level of thyroid hormones. So this is just a quick reminder, and I'm sure that most of you have thought about this at some level or the other. So a lot of the stuff that we have been thinking about COVID-19 comes from thinking about coronaviruses before COVID-19, in particular something called SARS. So SARS was a virus that was recognized back in the early 2000s, around 2002, 2003. And the particular features of SARS were that it was a respiratory infection. In other words, it infects the lungs primarily, but also affected other systems in the body. The second thing to say is that as far as the world, one of the reasons why SARS didn't turn itself into a pandemic was firstly that it wasn't quite as infective as what we now know about COVID-19, and but arguably it was a worse disease than COVID-19. In other words, people really did get very, very sick with SARS, and there was an awful lot of deaths, relatively speaking. And we call the virus that causes SARS is abbreviated SARS-CoV, SARS-CoV, standing for coronavirus. And the one that causes COVID-19 is like a cousin of SARS-CoV, and we call that SARS-CoV-2, right? So it's like a sequel to a movie. And what we knew about SARS from some research that was done back in the 2000s is that SARS infection can damage the thyroid, and there was some evidence that when people looked back into the thyroid, that the SARS-CoV virus could damage the thyroid. And the reason why we think that's the case is because there is a kind of molecule that is naturally expressed on the thyroid cells called ACE2. And this is a very important molecule because it's the entry, the door through which SARS-CoV and SARS-CoV-2 enter cells. And in particular, the famous spike protein that sits on the outside of the coronavirus sticks to this ACE2 thing. And that's how the virus gets into cells. And we find this in thyroid cells. So this was kind of like indirect information that the virus can get into thyroid cells. In addition to damaging the thyroid itself, we also had some evidence that SARS infection can damage the pituitary gland, and in particular, the cells that we're concerned about, those that are producing TSH. And you can see from the picture here that in a normal person's pituitary gland, there's a certain amount of TSH, which is indicated by the brown stuff here. And if you look at somebody with SARS infection, there's essentially less TSH around. And so possibly this could mean that their thyroid's less active. But, this was not, this was, I guess, the research in this was published, and people didn't really remark too much about it, to be honest, because SARS ultimately was an outbreak which essentially mostly affected the Far East, Japan, Taiwan, Korea, Malaysia, Singapore, etc. But it never really quite reached the. I mean, there were a few cases over in the UK, which I recall hearing about when I was working, but it didn't really seem to affect daily life over here. Anyway, that's what we sort of knew. And the specific thing that we're going to be talking a lot of, and I thought I would give a little bit of explainer here, is something called thyroiditis. Now, I'm sure that some of you will have had or been told that you suffer from thyroiditis. And the particular type of thyroiditis we're going to be talking about here is variously labeled as subacute or dequervain thyroiditis. And I have to draw this distinction here between Hashimoto's thyroiditis, which is way, way more common, which is what we call an autoimmune problem. Subacute or dequervain thyroiditis seems to be an immune reaction to viral infections and various other more common viruses which people get all the time, such as mumps virus, Coxsackie virus, adenovirus. These were thought to activate the immune system and somehow in certain patients trigger an attack on the thyroid, and the thyroid will commonly swell and can be painful. And what's happening here is that the immune cells are invading the gland and destroying it. And because the thyroid gland contains a lot of thyroid hormone in stores, it causes a release of thyroid hormone. So as shown in this red line here, you get a huge release of thyroid hormone. And initially, people turn up with what we call a thyrotoxic picture. In other words, very high thyroid hormone, and the TSH level is suppressed. So people look like they have overactive thyroid. But then as you go on through 3 weeks, 6 weeks, 9 weeks after the initial thing, the amount of thyroid hormone drops because the thyroid gland is destroyed, the stores are gone, and the production of thyroid hormone essentially stops. And you drop the free T4 level as shown by the red line here, and the TSH, which is a marker of underactive thyroid, goes up. And in most patients, we have this recovery. So essentially, within about 15 to 18 weeks, the thyroid hormone levels restore, because essentially the thyroid gland regenerates itself and starts making normal levels of thyroid hormone. And in most patients, they go back to normal. And so this is the sort of thyroiditis that people are concerned about. And this is, so as I said to you, there was a lot of publicity earlier in 2020 around where people were concerned about how COVID-19 might trigger thyroiditis, and these are the sorts of headlines that came up at the time. And so these are based on some studies. For some reason, they are mainly from Italy. And this is a picture of the normal structure of the thyroid. You can see that there's this pool of what we call colloid, which is like this pink blob here. And this is the pool, the store of thyroid hormone. And in here you see that there are lots of these tiny little cells here, which are basically immune cells. And what they're doing is that they're coming and attacking the what we call follicular cells that normally make thyroid hormone and blowing it up. But at the same time, what you see here is that these stores are being chewed up and being released into the blood, and that's what causes the overactive picture that we see initially. And so these reports from Italy suggested that for whatever reason, the people that were reporting this were seeing a lot of cases of thyroiditis. So this is to say these are cases of overactive thyroid in the early phase, which were not associated with the usual causes of overactive thyroid that we deal with, such as Graves' disease or goiters and so on. And initially there was one patient described, and then they turned that into 4 patients in what we call a case series, and they suggested that this was tending to happen, between about 2 weeks to a month after COVID-19 had settled down. And then larger series of patients. So basically, people started measuring thyroid hormone levels in patients that were being admitted to intensive care, for example, outside intensive care, and they were reporting that 1 in 7 patients, for example, of patients admitted to intensive care had features of thyroiditis, and another series suggested that 1 in 9 patients who are being treated for COVID-19 outside of intensive care also had signs of thyroiditis. So that was certainly quite alarming. And at the time we were reading about this and wondering, okay, what's going to happen here? Now the weird thing, of course, is that so I was working at that time on COVID wards, like everybody else, and I was thinking, well, look, we are admitting up to 30 to 40 patients a day with COVID-19. This is just that was true in the first wave back in March, April, and that's actually true now. And one of the things that if we assume that 1 in 10 or 1 in 11 cases have got 1 in 10, 1 in 9 cases have thyroiditis, then I should be getting a call, like literally every day. Every day I should be getting 3-4 patients with thyroiditis somehow. And the weird thing was that I wasn't getting any calls. I mean, yes, there were occasional cases of thyroiditis, but in most cases, they didn't seem to be particularly linked to COVID-19. So I wasn't really seeing much of this at all, which is a complete dissonance in terms of what was being reported in the studies and what I was seeing on the ground. So with this question in mind, the thing that I was wondering is what happens to thyroid function during COVID-19. And in order to do this, I got together with some colleagues working in Imperial College Healthcare. So this is Imperial College Healthcare is mainly based at 3 big hospitals over in the northwest of London, which is to say St Mary's Hospital down in Paddington, Hammersmith Hospital out near East Acton, and Charing Cross Hospital, which is weirdly next to Hammersmith. And we had some numbers that we'd actually collected together as part of an earlier study that we were doing on a different hormone, cortisol. And these were patients from the first wave, so between March the 9th to April the 22nd. And for the particular interesting thing about this data is that for whatever reason, Imperial College had made it like part of the standard that everybody got a thyroid function test when they came in with COVID-19. And in particular, we were looking for data where we are measuring both the thyroid hormone 3T4 and TSH. One of the key questions that we had about the Italian data that I mentioned to you before is that they were only kind of measuring TSH really, and occasionally measuring 3T4, which means that you're not really getting a complete picture of what's going on. Now, the main thing to say, and I think Lorraine mentioned this, is that we deliberately took out people who had pre-existing thyroid disease on the basis that the question we had is, what happens to people with normal thyroid function and they get COVID-19? If they had pre-existing thyroid disease, that let's say, for example, they had underactive thyroid, then that wouldn't really tell us much more, because if they got COVID-19, well, the amount of thyroid hormone that they got in their blood would mainly be determined by exactly how much thyroxine they were taking. So we took that out deliberately. We also took out people who were taking thyroid hormone medication or anti-thyroid medication, carbimazole, propylthiouracil, and things like that. Again, on the basis that what we read in terms of their thyroid function is influenced by what they're taking, and it's difficult to know whether that's an important thing or not. So we took that out. And there's a third category of person that we took out, and that's those people are taking steroids, which is to say things like prednisolone and so on, mainly because we know that steroids influence the way that your thyroid works. So this is a study primarily on people who, as far as we know, has normal thyroid hormone production before, and with asking the question, so what happens if they get COVID-19? And we ended up with 456 patients. 334 had confirmed COVID-19 on the swab. In other words, that thing that you stick up the nose and send to the machine, and you get the result of COVID-19. And we also compared it to 122 people without COVID-19, which is to say that they didn't have any COVID-19 on the swab, but we also had other information which suggested that they didn't have COVID-19, didn't have all the features that we know about. And what we found in general, that patients with COVID-19, and this is common to many other studies that people have been doing on people with COVID-19, is that those people who are admitted to hospital, and those are usually towards the more serious end of the infection, tended to be heavier, or more were diabetic, and in that time, more than 1 in 4 people died. So that's reflective of the population of people who tend to turn up to hospital with COVID-19. We know, as a generality, that most infections of COVID-19 in the community, most people do not die. They survive it, they get through it. A lot of people are effectively asymptomatic. That's a big problem, because there's a lot of people walking around with COVID-19 without symptoms who are kind of shedding it and spreading it. A lot of people essentially have mild symptoms. In other words, they know they've got COVID-19 because they've got a fever, they've got a cough, and some shortness of breath, but it's never developed to the point where they really need to come to hospital. They stick it out at home, for a week, 2 weeks, and so on, and then recover. So the fact that 1 in 4 people died in this series is just simply reflective of the fact that these are people who are turning up to hospital in the first wave. Relatively speaking, we didn't really have all that many treatments at the time, apart from oxygen, and that's what the mortality rate. So I just want to make sure that you don't take away the message that a lot of people die from COVID-19 as a whole in the population. Most people, by far the vast majority of people, survive COVID-19. And this is certainly more than people who this death rate was certainly more than people who didn't have COVID-19. So we are taking it seriously. This is a big problem. 1 in 8 people with COVID-19 ended up in intensive care and so on. So the first thing to say is that, and this is one of the surprises that we got from our data, is that actually most people with COVID-19 have perfectly normal thyroid tests. So about 86.5% had perfectly normal thyroid function test. And it was exactly the same whether you did have COVID-19 or didn't have COVID-19. In other words, it was no more, no less than what you'd see in people without COVID-19. And second important point is that this overactive picture where you have a high hormone level and a suppressed TSH, we saw absolutely zero, nobody with that picture. And this is this is different from the Italian data we're telling you about, where they were seeing people that they reported overactive thyroid, 10, 15%, that sort of thing. And we saw absolutely zero. A couple of people had classic underactivity of the thyroid, but not an awful lot. And what we are seeing more often is either this picture of so-called mild hyperthyroid, where the actual thyroid hormone levels are normal, but the TSH is slightly low, or a mild hypothyroid, where the free T4, again, the thyroid hormone is normal, but the TSH is slightly high. So we're seeing a few of those. And so this so-called pituitary hypothyroid, where we see where the thyroid hormone level is low and the TSH coming from the pituitary is low. We saw a couple of cases of this, 8 cases in our COVID patients, but not an awful many. So the main thing you have to take away from this slide is that most patients, by far the vast majority of patients, COVID-19 have absolutely normal thyroid tests. But what we did notice is that if you actually dig into the numbers, is that there's a tiny change in the numbers between people who don't have COVID-19 between those who do. This is a TSH graph. So in people who don't have COVID-19, we found that their TSH was on average about 1.5 or so, and this dropped to 1, around 1. And this was, we do our statistical tests and so on, and that was found to be, yes, there's definitely a difference. Similar thing with free T4. So we found that on average, people without COVID-19 had free T4 about 13, and this dropped to around 12 with COVID-19. But importantly, when we broke the patient's population apart into people who survived and didn't survive within their admission of COVID-19, we didn't really see that there was any influence of free T4 and TSH on survival. And this is different, for example, from other hormones such as cortisol, where we did see that higher cortisol levels are associated with smaller survival. This is a different thing. So that's what we found. Okay, so that's just people that coming through the door with thyroid, with COVID-19, that with thyroid hormone levels. Now, we now ask a slightly different question. So, what happens? So we're all aware that actually, when we look, when a doctor looks at your thyroid test, okay, so you go off and have a blood test, and that's returned to your GP or to your specialist, and the doctor is going to be looking at this thyroid test, and you know that next to the thyroid test there will be a couple of numbers, right? So the so-called reference range. So typically, for example, at least in our hospital, we say free T4, and then next to it is put the number 12 to 22 in our hospital. It can be different in other assays. And the same thing applies to TSH as well, right? So, TSH, you get a number, and then next to the thing is printed a particular reference range. Now, the important thing to know about thyroid hormone numbers is that actually, in a particular person, their thyroid hormone number is kind of special to them. So let's say that your thyroid hormone 3T4 level is around 13. Actually, as time goes on, assuming that your thyroid hormone level, your thyroid's operating normally, it will vary, but it won't vary that much. It will be something like between 12.5 to 14.5, at the outside 15. So the particular thyroid hormone level for one person, let's say 13, is special to them, and they will vary, but they won't vary that much from that number. Other people will have, let's say, 18 as a special number, and they'll vary between 17 and 19, let's say, but they will tend to run at that level. Other people will have something much lower, like 9, and they'll vary between 8 and 10, but they won't change that much. So what we wanted to do is to check whether there was any change from someone's thyroid level before they ever saw any COVID-19, and when they came in with the infection. And also, the second question we had is, what happens to thyroid function after you have COVID-19? So the way we did this is that we used the same set of patients, but we started looking before and after the admission of COVID-19. So we looked for thyroid tests that had been done in 2019. Now, 2019, I have, to be honest, I have I have some difficulty recalling what 2019 was like, to be honest. But that was a time before COVID-19. We did not have COVID-19 in this country. And so we took that as like a baseline value. And we had a few patients that had been admitted to COVID-19 in that time period of March to April who had come back since. And obviously they were survivors. They had survived COVID-19, and some of them had thyroid function tests. So we also had these follow-up thyroid function tests as well. And we basically looked for people who had a thyroid function test in 2019, one when they came in one which was done when they came in with COVID-19, and then another one which was done after COVID-19, and they come back to a clinic for follow-up. And so this just simply reflects, this data shows that when we compare and contrast in each person their blood tests when they came in with before COVID-19, when they came in, and then when they were followed up, is that as far as TSH is concerned, they had a certain amount of TSH when they came in, when they had their blood test in 2019. It dropped when they were admitted with COVID-19, and then it bounced back up again when they were followed up, which is, in a sense, quite reassuring, because it tells us that, firstly, that drop in TSH is a thing. It does happen during COVID-19 infection, but when you follow them up afterwards, the TSH goes back up to effectively at the same as when they were back in 2019. This graph is to do with 3T4, and we didn't really see much change. One gets the impression that there's a small drop in 3T4 and then it bounced back up again. But technically speaking, we didn't prove that statistically, primarily because we only had a tiny number of people with that. But we definitely saw this with TSH, where we had more people with complete data. And so we are clear that when somebody comes in with COVID-19, their thyroid function tests are slightly depressed compared to before the infection. So we wanted to know, how could this occur? And we have a few theories about that. The first and probably the strongest theory is something that we call non-thyroidal illness syndrome, and that's a mouthful, I must say. But what this simply means is that if you're ill, and if you're ill for any other reason other than the thyroid going wrong, this could be a chest infection, it could be a bowel infection, it could be the fact that you're having surgery, all sorts of illnesses. The body reacts to this by changing how thyroid hormone is made, how thyroid hormone is transported around the blood, how thyroid hormone is processed in order to do its work, and how it works on cells. Okay, so in order to understand this, I'm just going to introduce this idea of deiodination. I'm sure a lot of you know about this, but just to say that most thyroid hormone made by the thyroid in humans is this thing called T4, and we call it T4 because it's basically got 4 iodine atoms. So 1, 2, 3, 4. So that's T4. It's got 4 iodine atoms, and they're stuck to these hexagonal things which we call rings. And there are 2 rings. There's an outer ring, and there's an inner ring. And deiodinases are basically enzymes that sit in the tissues of your body, which basically pull away 1 iodine atom and turn T4 into T3. And that's T3 is when you take away the outer ring iodine atom. And T3 is actually the active thing which activates the thyroid hormone receptor in your cells. And however, there are other enzymes which can pull away the inside ring iodine atom, and that's known as reverse T3 because it's like the mirror of T3. And reverse T3, as far as we know, to a greater or lesser extent, doesn't work. Unlike T3. So T3 seems to be active, reverse T3 seems to be inactive. And then later on, when you take away more iodine atoms, you get T2, and T2 is completely inactive. And what we know about illnesses is that if you have a mild illness, one will see as one of the first responses that you get an increase in reverse T3 and total T3 goes down, because what's happening is that the body is basically sort of switching from a mode where it's usually making T3 to a mode where it's making reverse T3. And this is without necessarily affecting too much how much TSH and T4 is being made. But as you get into more severe illness, and we're talking about, in our study, people who have really fairly severe COVID-19, what will tend to happen is that TSH will tend to come down, the free T4 will tend to come down, T3 becomes suppressed to near 0 levels, and reverse T3 becomes really, really high. And we think that this is in response to what we call inflammatory chemicals. So these are chemicals which are made by the immune system during infection, like IL-6. And this is basically what it's doing is that this is what we call an adaptive response. In other words, the body is needing energy to fight off infection. And what happens is that during the infection, it's reducing the amount of energy that it spends on your metabolism. And that's what we think this is. So we think that actually, as far as people with COVID-19 is concerned, the explanation for the changes that we see in their blood tests is probably related to this so-called non-thyroidal illness syndrome or response. And there are other reasons why there might be a slight depression in thyroid hormone. I mentioned earlier that the virus could be affecting the pituitary gland. And we also know that COVID-19 stresses the body. So high stress hormones such as cortisol are produced. Cortisol can suppress TSH production itself. So we did see a little bit of a relationship between high cortisol levels and TSH levels being lower. So that's also a possible mechanism. So I think I've taken an awful, oh my God. So I've actually gone through, this has taken double the length of time I thought I was going to take. But anyway, I'm just going to.
It's great, Bernard. Don't apologise. We're all glued to what you're saying, and you're presenting very well. So don't worry. We've got some flexibility in the timescale.
Okay, so I'm just going to round off with a few more slides. So the first thing to say is that there is this story that COVID-19 is associated with thyroiditis. So this is the so-called subacute or dequervain vein thyroiditis, not the Hashimoto thyroiditis. And there was a lot of suggestion that this could affect as many as 1 in 9 patients with COVID-19, but we're not seeing that for whatever reason. Maybe it's something to do with people being in Italy, and we know that there are differences in iodine exposure between different regions of the world. So possibly this is I have to say this is a hand-wavy explanation, not anything I have real evidence for. As far as London is concerned, the UK maybe, we see that COVID-19 causes small drops in TSH and free T4, thyroxine. But they're small, they're tiny reductions. Not really enough to justify dishing out more thyroid hormone to people. And we think this is most likely due to this non-thyroidal illness syndrome. As far as we can see, these changes appear to recover by follow-up. So when people recover from COVID-19, we see the changes reversing themselves back to where they were back in 2019. Now, I'm sure that everybody's aware of this so-called long COVID syndrome of chronic fatigue and various other things and shortness of breath and so on. We still have some active research going on into thinking about whether these persisting hormonal problems may be responsible for long COVID syndrome. So this is something that we're researching into, but we have no new information about that. The other thing that we did talk about in our paper is that we thought that actually just measuring thyroid hormone tests in patients with COVID-19 is probably not a necessary thing, and we could probably avoid doing those tests unless we had some reason that they had a thyroid problem. For example, if they perhaps were taking thyroid hormone because of underactive thyroid and so on. So one general question I would just want to talk about is, do you, if you have thyroid problems, need to be worried by COVID-19? The general answer to that is no, not really. Most people in this country who have a thyroid problem will have underactive thyroid, that's statistically. And generally speaking, we don't think that you really need to shield in general. And the only key exceptions to that is if you happen to be taking high-dose steroids, for example, for eye problems arising from Graves' disease, or if you're taking special chemotherapy for thyroid cancer. If you have an underactive thyroid, if you have hypothyroidism, there are more recent studies where they looked at people who came into hospital with underactive thyroid and looked to see whether there was any change in their mortality, in other words, their rate of death, compared to people who have normal thyroid hormone levels, and we couldn't see any real change in outcomes. So it's not we, but the people who did the study couldn't see any real change in outcomes. So as far as you can see, if you have underactive thyroid, you should continue to take your tablets as usual, even if you contract COVID-19, and there's no real evidence that poses more of a risk. And as far as medications for hypothyroid is concerned, the carbimazole and propylthiouracil and so on, we don't think they're likely to affect the body's response to COVID-19 infection. You'll be aware that we are always looking out at white blood cells with these medications, but as far as we can see, provided that the white blood cells are not affected by medication, it's not going to affect the body's response to COVID-19. Obviously, if the thyroid medications do cause problems in white cell counts, then that can affect your body's response to infection. And in those cases, we make sure that we stop the medication and to avoid and try to avoid you getting infected. Okay, so the next general question is that I keep being asked about by everybody in my endocrine practice, not just people who are underactive thyroid. Should I have the COVID-19 vaccine? The answer to that is very strongly yes. There is no reason so far that we can see that if you have a thyroid problem that you should not have COVID-19 vaccine when it is offered to you when it's offered to you by a GP. The double-edged sword, I guess, for the fact that we don't have any evidence that thyroid problems cause any more problems with COVID-19 is that, generally speaking, you're not going to fall into those categories of people who are more vulnerable with chronic conditions, are more vulnerable to COVID-19 infection. Therefore, generally speaking, you would be treated more or less like somebody of your age group. So that's my last slide. I just wanted to thank my collaborators, and mostly to Professor Tricia Tan, and also to Professor Walter Dillow, and also to all the other doctors who very helpfully and quickly put together all the data which I've been talking about. And with that, I'm just going to take your questions.
Bernard, thank you so much. What a beautifully delivered, may I say, and very, very interesting presentation, and I think very reassuring for us as thyroid patients as well. I'm seeing lots of questions have coming in the chat, and also lots of expressions of thanks to you for such a good and interesting presentation. And some interesting observations as well, which we'll get to discuss. We're just coming up to 8 minutes to 12. So let's take that. I'll just do some announcements in a moment, but let's take a little break, 5 minutes comfort break, as we said, and then come back and have the Q&A session. Can I just quickly, Karen and I, do the announcements that we have to share before the break, because those might be things that people want to sort of have a think about, and they might have questions when they come back as well. Karen, did you want to start with the stuff that you had to share?
Yeah, so thank you. The first one was just to say a huge thank you to Mary Saunders, who January was Thyroid Awareness Month in the States. So Mary took the opportunity to do some fundraising for us, and she donated for every 5K that she ran during January. She made a donation, and she asked her family and friends to support her, and she raised an amazing £140 to support the work of the Thyroid Trust. So thank you, Mary. That's just incredible, and we really appreciate it. Also, if you didn't know, May is actually there's a International Thyroid Awareness Week at the end of May, and the 25th of May is International Thyroid Awareness Day. So last year, some of us got our running shoes on and our cycling shoes and various other bits of regalia, and decided to raise some money for the Thyroid Trust and help to raise awareness of sort of thyroid disease. So Lorraine, Helga, Stephen, Mike and myself all did various activities, and you can read more about them on the website and look at our Instagram page as well to see some of the photos. And we thought it'd be nice to do something this year as well. So if you'd like to join us in that, it doesn't necessarily have to be activity. We're looking at various other ways that we can sort of mark the occasion and help to raise some funds. So we're going to have a little sort of thyroid cafe event on the 26th of March, which is a Saturday morning, from 11 o'clock till around noon. So if you'd like to join us just to have a chat about how we might sort of mark International Thyroid Awareness Week, it would be lovely if you could join us on that day. It will be over Zoom, obviously, because I don't think we'll be able to meet face to face by then, unfortunately. But we'll send out details via the mailing list as we usually do.
Brilliant, thank you, Karen. And yeah, we had a lot of fun last year, and it would be great to sort of make even more of an impact celebrating International Thyroid Awareness Week here in the UK this year. So I hope some of you might be up for that. You might have some ideas, things that we can do. So a couple of other announcements. There's a couple of really interesting research studies going on at the moment that people have the opportunity to get involved with if they'd like to. There's a big international study taking place with a number of leading clinicians. It's called the Empathy Study, looking at experiences of people with hypothyroidism. And that was due to finish in January, but they're running it now until the end of February. They want to get more than 10,000 responses from people. And I know that some people who've taken the survey, and I have to say myself as well, we've kind of got some questions and concerns about some aspects of what they're asking. I think it would have been nice if they'd involved patients a bit more in scoping the questionnaire before they put it together. But they did work with Thyroid Federation International, who liaised with us. So it's always a process, isn't it? you know, we would be really, really glad if people would take that survey, and there's a free text field at the end where anything that you haven't been asked that you wish you had been asked, or anything that you want to say over and above what you've said in answering their questions, you know, you can say as much as you like to them. So please, please, please take that study, and you can find it. It's on our Facebook, it's on our website. If you go to the information pages and research pages, you'll find that. And then just this week, the British Thyroid Foundation have announced that they're working with the University of Newcastle, and they're doing a pilot study at the moment into experiences of people who have been treated for hyperthyroidism, either with radioiodine treatment or with surgery, and they want to hear about people's experiences. And that's really smart the way they're doing it, because they're asking a sort of a relatively short number of questions to begin with, and then they're going to use the answers that they get to help them shape a bigger study, assuming they can get funding for it. So that's a really exciting one. We've tweeted about that. I will put it on our Facebook page. In fact, I'll send you all a link to it after this meeting. I'll send you all a link to both of those studies. It's probably the easiest way. And we'd be really, really grateful if you could share those with any other patients that you think might possibly be interested. Just wanted to mention that our first annual report is now on our website, which takes us up to the period of June 2019. So if you want to sort of scrutinise more what we've been doing and our finances and stuff, then you can do that. It's on the About Us pages of our website, annual report. And we're working on our second annual report, which will take us up to the period of June 2020. So that's going to be an interesting one, because obviously it included some of the pandemic. So we're proud to have done that, and hope that it's the beginning of many more years of doing even more to make a difference for thyroid patients. As I said at the beginning, we are a new charity. We've only just completed our registration in 2019. It's very, very early days for us. Our continued existence is still, to be frank, quite precarious. So, huge thanks to everybody who has supported us in any way thus far. If you're in a position to, we'd be hugely grateful if you can going forward. One way that you can really help us, nothing to do with money, is please share any of the posts that you see us putting out on Facebook or any other channels, in any groups or forums that you might be a part of where you think people would be interested. Particularly on Facebook, it's really difficult to get your posts seen unless you give them advertising money, which we don't have the budget to do at the moment. So please, if you can help us with that, that would be great. We've got some really interesting content coming out soon. So Bernard has very kindly agreed for us to record his talk, which we will be sharing online, not straight away, but soon. And in the meantime, we're going to be publishing 2 new films of previous information events that we've run. So some of you will know that last September, we had a fantastic talk from Professor Atul Kalhan, who gave a talk on lessons learned from a patient that a book cannot teach, which was a really interesting talk. And we're going to be premiering that on our YouTube channel next Wednesday at 7:30 p.m. So please join us for that. The reason for doing it on a premiere is that it means that people know when it's going live. They have the opportunity to watch it at the same time, and there's like a chat function on YouTube, so people can chat about the film if they want to. And then the following, and then after that, it will be available to watch anytime you like, both on YouTube and on our website. And then in November, we had another fantastic talk from Torkel Watt from Denmark, from Copenhagen University, and he's the creator of the ThyPro tool for measuring quality of life in thyroid patients. And he told us all about that, which was really interesting. We're hoping to do some follow-up work with him on that. So that's going to premiere not next Wednesday, but the following Wednesday at the same time, 7:30. Just wanted to mention very briefly, some of you will be aware that we've been very involved with a number of partners in working to improve access to liothyronine for the small number of patients who need it on the NHS. And you will know that the NHS and the Department of Health have said to us very clearly on numerous occasions that any patient who requires liothyronine should be prescribed it on the NHS. And many of you will know also that there are a lot of local health authorities who are making that very difficult for doctors to prescribe and for patients to get the treatment they need. And it's a really difficult situation. So we're continuing to work on that. We had really a good letter from NHS England just before Christmas, signed by 2 very senior people at NHS England and NHS Clinical Commissioners, which is the body responsible for all the CCGs, basically reiterating exactly that the national guidance states that patients who require liothyronine should have it on the NHS, and there's a prescribing guidance which we were influential in having published in 2019, which they refer to and which is also referred to in NICE. So we're hotly pursuing getting that word out to CCGs. Somewhat annoyingly, NHS England have said that they're not allowed to write to CCGs about this at the moment, but understandably, because there is a global pandemic going on and the resources are very, very stretched. But we're talking to parliamentarians, including Lord Hunt, who's supported us from the beginning on this, and the MP in Brighton is expressing a lot of interest in getting more involved with this. And Helga, fabulous Helga, has completed a review of policies of for liothyronine prescribing in all the different CCGs around the country, which we are going to be presenting to NHS England and other stakeholders who can make a difference. So just really to give you that brief update that we're very, very hotly on the case with this. We've been invited to a meeting with MHRA, and we have a number of specialist clinicians who are very interested in that meeting and will be joining us for that. And we've been approached by a GP who has suggested that we produce an educational video for GPs that summarises the key points from the NICE guidelines about treating hypothyroidism well, and also signposts them to the remote prescribing guidance so that they're aware of it. So we're hoping to get a specialist to work with us to put that video together. And the GP who's approached us has some very good media contacts. So and we're talking to the RCGP about it, who have expressed potentially interest in supporting it. So that's quite exciting. That's our announcements. A lot of this you actually answered in your presentation. Bernard Diana says, I'm particularly interested in Graves' disease. Are people with Graves' disease at higher risk of bad outcomes if they get COVID-19? What are the risks of the vaccine for people with Graves' disease? Was the efficacy of the vaccine for people with Graves' disease? She says there's suggestions that people with such autoimmune diseases aren't very efficient at making antibodies. And she says, do any of the answers about risk and efficacy differ depending on which vaccine is given? So I think you've kind of answered that in your last slide, haven't you?
Yeah, so as far as people with Graves' disease are concerned, are they at high risk of getting bad outcomes if they get COVID-19? The answer is, frankly, we don't really quite know. However, one could say that if the Graves' disease is not controlled, in other words, you have an overactive thyroid, at the time that you contract COVID-19, you are possibly at high risk of getting complications. The reason is because COVID-19, as you know, places a stress on various different bits of the body. And if you've already got a pre-existing Graves' disease, which overactive thyroid, then that's also another strain. So essentially, it's on the principle of addition of different conditions together that you are possibly at greater risk of having bad outcomes if the Graves' disease was not controlled properly. If your Graves' disease is treated and your thyroid hormone levels are actually at a reasonable level, provided that you're continuing on medication and the thyroid hormone levels are controlled, then I don't perceive that there's any high risk per se from just having Graves' disease. Now, with regards to the risks of having vaccine for people with Graves' disease, we don't know of any risks. So almost certainly in the trials, there will be a bunch of people with Graves' disease who have been recruited into the trial. The data that I've looked so far at the published studies on the vaccines that we have so far, they don't particularly highlight thyroid disease or Graves' disease as being a risk factor for side effects, or even that there's any difference in efficacy. It's for all vaccine trials, these are all very, very early data. So perhaps something will come up in the future. We don't really know, but so far we don't really have any evidence that people with Graves' disease are going to get less bang for buck from the vaccine or have any more risks or anything like that. And in general, if there's going to be any difference, it's going to be relatively small, and you're still going to get quite a good protective effect from the vaccine. That would be my thinking. So again, the advice that I gave holds, that if you are offered the vaccine, you should go off and get it.
Yeah, great, excellent. Dika's question was exactly the same. What are the effects of the vaccines, particularly Pfizer, on thyroid hormone function? But then her second question, which hasn't been addressed and is very specific and very interesting, she says, generally, do thyroid hormone functions or levels vary depending on race in any significant way? Is that significant? That's an interesting one.
Okay, so I'm just going to go for the first questions first. So what's the effect of vaccine on thyroid hormone function? The answer is I don't really know, because the data hasn't really been published. I'm aware that during these trials, almost certainly they will have measured thyroid function during them, but so far we haven't had any particular data that suggests that Pfizer, any of the COVID-19 vaccines affects thyroid function, and frankly, I'm not sure that I would expect it to. It's not, in a sense, these are two very different domains. The whole idea of a COVID-19 vaccine is that we are essentially making spike protein, which is this particular component of the coronavirus, which is, as I was saying, important in sticking the virus to the cells into which it's trying to get into. And what we're trying to do is trying to get the antibodies to come up against that spike protein, so that if and when you do get infected with coronavirus or see coronavirus, that the immune system will recognize it immediately, glom onto it, and stop it from getting into cells. So whether this affects thyroid hormone function, I'm fairly sure that it's probably going to have a minor impact, if any. Now, the second question is actually a little bit outside of what we have here, and I'm just going to make this point. Frankly, I don't find categorization of people by race terribly helpful, to be honest. Mm-hmm. I would emphasize to you that thyroid hormone levels are individual. Okay, mm-hmm. So as I was saying before, people have a number, as it were, like a level of thyroid hormone at which their body is most comfortable, and that number will vary a little bit from day to day, depending on the temperature, the weather, how somebody feels, and so on. But that number is individual to a person, and I think what you need to get away from is the idea that there are vast differences in terms of when you blob people into, so and so's black, so and so's white, so and so's, Asian, whatever, and I'm not aware of any study which shows that there is any in those blobs any major difference between races in terms of thyroid function.
Yeah, no, that's really good to know.
I would emphasize really that whenever I'm thinking about treating somebody with a thyroid problem, I'm not thinking about a race at all. I'm thinking about the individual person.
Yeah, and that's so important for patients to hear, that doctors see us as individuals and recognise that every individual patient might have slightly different needs, and that would be really reassuring for Dika, I'm sure, to hear that there's no evidence that different races are showing. Race is a bit of an artificial construct, isn't it? But people with different ethnic backgrounds are not. There's no evidence of there being any difference in what's happening with thyroid function there.
Yeah, let's put it this way. The levels of thyroid hormones, when we take thyroid hormone levels from hundreds or maybe thousands of people, is a very broad church. It's huge variation. So as I said to you, our standard reference range is between 12 to 22. So it tells you that some people exist on half the amount of thyroid hormone that that other people seem to require. Yeah. And as I said to you, I think it's a terribly broad church, and one starts sort of like chunking people up into, you know, so and so's white, so and so's black, and so's Asian, and so on. These are huge categories of people.
Yeah, it's just not helpful.
And I'm not sure it's terribly helpful to do that, because you'll see, I think actually almost certainly you'll see that people will come up with big blobs of big ranges of thyroid hormones, which overlap very much with other races. So in which case, it's not really terribly helpful to talk about race as an influence.
Great. No, that's really helpful for everybody to know.
So I was going to ask, there's been a lot of questions around the T3 aspect to it. So in the study, was T3 measured, and is there going to be a trial to see if T3 has any impacts? I picked up on a study, which may be an American study, about low T3 in lungs of patients with COVID.
So I'm going to address that one. I looked at it, and there isn't an awful lot of information about it. It seems to originate only in one center, and it's a hypothesis that they've had for quite some time. And effectively, they posed that about flu virus. And their theory is that when somebody has a respiratory infection, whether it's flu or perhaps COVID-19, the levels of T3 in the lung epithelial cells are relatively low, and their hypothesis is that, you know, if you've got somebody with a tube down the throat in ITU, that if you squeeze T3, sorry, I'm getting a lot of interference.
Yeah, there's a lot of background noise. Can everybody who's unmuted mute themselves, and then we will unmute you when you need to speak. Otherwise, we can hear what's going on in the background that's causing interference. Thanks, everyone. That's great. Carry on, Bernard.
So I think they have this idea that because at least on some small studies that we've done, there's a lack of T3 in their samples in lungs from people who have respiratory infection. And this is not COVID-19. This is things like flu. That the theory is that if you shove T3 literally in a liquid down the tube into the lungs, that will help people. And they've got a study, and I think they've got they've started doing a study. As far as I'm aware, I have no idea whether this stuff actually works. As you'll probably be aware, the important advances that we've had in COVID-19 treatment, you know, things like steroids, and now this thing called tocilizumab and saralimumab, they have come from, you know, properly conducted British studies where we've actually, you know, given some patients a treatment and other patients treatment, and also importantly, you need to have lots of patients. And from the details I have on this particular study by the American group, to be honest, they're talking about tiny numbers of patients, and I'm not sure it's necessarily going to tell you all that much. I'm not holding that much hope that it's going to tell us that much about whether T3 really is something that we can stick down the breathing tubes in order to reduce problems with infections like COVID-19.
One of the things that I saw a few people asking, Bernard, just following on from what Helga was saying, is you know, TSH and T4 were measured in the patients that you were monitoring, but it didn't look like you were measuring T3. And was there a reason for that?
Well, the first thing to say is that T3 is not something that we routinely measure.
Yeah.
And certainly wasn't routinely measured in our patient cohort.
Yeah.
Right?
So you didn't have the data.
The second thing to say is that the question we had at the time really related to this question of do people have overactive thyroid, essentially? Yeah, because of this early data which suggested thyroiditis, which presents itself at least in the early phases as usually overactive thyroid. So that was the question that we had in our mind.
Yes.
Now, T3. Well, actually, you know, there has been a very helpful study from Hong Kong done by Professor Lam, where they actually basically measured T3 in people with COVID-19, admitted to COVID-19, do in Hong Kong. And in fact, only 12 out of 191 patients had low T3, 12.
Interesting.
So less than 10%.
Yeah.
And they felt that actually this was consistent with this so-called non-thyroidal illness syndrome. So is it going to be useful to measure T3 in patients with COVID-19? The answer is, in the vast majority, above 90%, probably not. Now, this is the thing about T3, though. Yeah, we recognize, and we've gone through this in the talk, that patients who are ill for various different reasons, and these are people in ITU who are ill, we recognize that when you measure their hormones, you're going to see, as I said, generally speaking, a low T4, a low TSH, a low T3, and a high reverse T3 when you measure that. The question is, does giving hormones to that, like T3 or T4 to that, actually improve outcomes? And the answer is, we don't have any real decided evidence that actually improve our outcomes. And the reason why I just want to say I think this is the case is because, in a sense, the low T3 is not the issue. The low T3 is simply a reflective of the fact that that the body is trying to conserve energy, it's trying to turn down the heating, as it were, right? And trying to give T3 on top of that, is a bit like trying to reverse what the body's trying to do in terms of conserving energy, and jumping in and giving somebody T3 or T4 in that context may be counterproductive, because you're kind of trying to reverse what the body's trying to do to protect itself, in a sense. So I think you got to be very careful about interpreting this stuff, because yes, we will see low T3 in at least some patients, but what we do about that is another matter entirely. That's ultimately what we're interested in as doctors who are treating COVID-19 patients. What are we going to do about all these numbers? And
Yeah, Helga, did you want to say something else?
Yes, so one of the other themes that's coming out of the questions is, what are the next steps with the study, and will you be monitoring outcomes for the patients? And
so we have follow-up studies ongoing. As you know, people are getting increasingly interested in so-called long COVID and things like that. Now, the interesting things that are emerging from this are that long COVID seems to be related to this entity that people have called chronic fatigue syndrome, or sometimes ME. And for many years as endocrinologists, we've seen a proportion of people with these types of symptoms, and quite often, and then there is some evidence to suggest that these patients appear to have a lower free T3 than people without. And I think it's likely that if we do measure free T3 in people with so-called long COVID, we will see a kind of similar pattern. Now, it's a situation in which it's difficult to know what to do about that. Again, what we think is happening with chronic fatigue syndrome and possibly long COVID is that because there's a kind of like continuing low-level illness, which happens to have been triggered by the viral illness, whether it's COVID-19 or whatever, which in turn is keeping the body in that non-thyroidal illness mode for longer than what you would expect in terms of recovery. And that's what we're seeing in the blood test. What we're seeing is that people are in that mode for longer than they should be. Now, that, in a sense, is not, again, the question comes down to, yes, we see a low, maybe we see a low free T3 in these patients. So what are we going to do about it? Is it reasonable for people to give T3, for example, or T4, doesn't thyroid hormone, to these patients in order to lift everything up? And the answer is, well, it's not clear to us that that's actually the right move, because again, as I was saying to you, this low T3, high reverse T3 mode, this mode of energy conservation, is an adaptive response. In other words, it's something that the body's trying to do in order to cope with a chronic illness of some sort. And it's equally possible that if you try to short circuit that response by artificially increasing T3 or T4, that this may be in the long term a harmful thing. And we really don't know unless we can conduct trials to see exactly what happens in the long term. And that in a sense is is tied up in this whole bigger issue of whether we should give T3 or T4 to patients. Clearly, some patients benefit from having T3 on top of their T4, but whether that's a in a sense whether that's doing them good in the long term remains to be established.
And that's such a huge and fascinating topic that we could talk about all day, and we would love to know more.
Yeah,
about
so I think I'm swimming out into rather deep waters there. So
yeah,
I'm
no,
going
exactly.
I'm now going to retreat to a little bit more shallower waters, because
no, well,
because
in
it's
fact,
a huge thing. Yeah.
In fact, it's 12:30, which is our closing time, and I'm mindful that we have lots and lots of questions specifically relating to your talk, which we haven't got a chance to get to. So, but we do need to finish, because people will have, yourself as well included, I'm sure, Bernard, will have planned to be here from 11 till 12:30, and it is now 12:30. Can I suggest, if it's all right with you, Bernard, that we send you a copy of the questions that we didn't get a chance to answer, and maybe touch base when you've got time to think about what the best way might be of answering those questions. I know you're incredibly busy, but maybe if we just follow up with an email, would that be acceptable?
Yeah.
Yeah. And I just want to apologise hugely to everybody who didn't get a chance to speak and who didn't get a chance to ask their question. We always have this situation in these meetings. When we do our face-to-face events, it's a 3-hour event, and you always have a really highly engaged 1-hour-long Q&A session. And we took a decision at the start of doing our online events that we couldn't expect people to sit online for 3 hours. It just doesn't work. But we have this recurring issue that we run out of time and we don't get to ask all the questions. So
I just going to make one more general point. One more general point is that there's an awful lot of theory and speculation out there about COVID-19. And again, this is the environment in which this is literally a 1-year-old disease, and we're still discovering new stuff about that. And the issue is that theory is nice, but when the rubber hits the road, we as doctors are interested in knowing, okay, should we give treatment X to this patient who has COVID-19 so that they get out of hospital faster, they get back to their families faster, and so on. And in terms of the thyroid, I'm seeing here, at least for now, that that's until we have proper clinical trials of giving thyroid hormone and all that sort of stuff, I at the present moment would not be saying that there's a strong case for us dishing out thyroid hormones routinely to COVID-19 patients until somebody comes out with a study and says, okay, we gave thyroid hormones, they came out better. We didn't give thyroid, they came out worse. Then we've got a case for it.
Yeah, that makes absolute sense. And I guess the other thing that I'm sure probably a lot of us in the room are would be keen to know about and would love to happen is, could there be any plans to do any research specifically into people who already have thyroid disease and the impact that COVID-19 might have on them?
Yeah, we already have some of that evidence.
Great.
So with regards to hypothyroidism, because it's super common, we've already got some evidence on that, and the answer is doesn't seem to make a difference. So that's a big reassurance. It's 1 in 50 patients have got underactive thyroid. It's a huge constituency of people, and we've got, broadly speaking, reassurance that this is not a thing for COVID-19. You're no more, no less at risk of getting COVID-19 given your age and your sex and other stuff that we know that affects your risks.
And that is really very reassuring for people.
Yeah, and as far as overactive thyroid is concerned, I think, as I said before, the key thing is that if somebody already has an overactive thyroid on top of COVID-19, that's probably not going to be good news. So we will need to treat both of them on their own merits.
Yeah, and as anybody with overactive thyroid, it's a more difficult illness and it needs more attention.
Yes.
Well, listen, thank you so much for such a great talk. Thank you so much for agreeing that we can follow up with you and think about how we can address the outstanding questions. Thank you so much to everybody for coming and for being so patient with us. It's really difficult doing things in the pandemic and everybody's online and everybody wants to talk about this stuff because it is so interesting. But it's great that we've been able to have this event and so brilliant to see such a good level of interest. I'm going to email you all shortly the links to the hypothyroidism and hyperthyroidism surveys that I mentioned. And I'm also going to send you a link to please fill out the feedback form and tell us how today has been for you. We want to know, anything that you think we could and should be doing differently. And of course, we love positive, kind feedback as well. But, don't hold back if you've got constructive criticism to offer. We're learning all the time and, consistently trying to do things better. As I say, we're little and we're stretched for resource, but we're going to be doing more of these events, and the more we have feedback for how it's been for people, the more helpful that is for planning ahead. And just to say again, if anyone has been and has loved it and didn't happen to make a donation when they were booking but could afford to and would like to, then of course we would be thrilled if you would do that. But that's no pressure at all. We're determined to keep fundraising from sources where money is available to keep going, and we'll continue to do that. Huge thanks to Karen and Judith and Helga for the support today, and the biggest thanks of all, of course, to Bernard. Again, thank you for giving
Thank you, guys.
Saturday. Thank you so much.
Bye.